All right, chapter 34, geriatric emergencies. We'll run through this. So, your geriatric patient, why are they different from your regular patient? What makes them different? Obviously, they have more brittle bones. They're more likely to have falls, breaks. Something you got to watch out for. So, age-related changes. After 30, organ systems lose 1% of function each year. After 30, organ systems lose 1% of function each year. I would probably remember that. I am turning 31 this year, so I will have 1% of function loss each year from after 30. Maximum heart rate declines. Older patients with internal bleeding will not exhibit heart rate as rapid as expected. And a lot of these patients are on beta blockers, which slows their heart rate as well. If we're not aware of this, an EMT could miss that the patient's actually in shock. So we got to watch out carefully on our geriatric patients. Patients have communication difficulties, geriatric patients. They have changes in hearing, vision, memory, and dentition. Residual effects of stroke or dementia can cause problems. Assume altered mental status as the result of an illness or injury until proven otherwise. We got to always try to communicate directly with an older patient rather than asking others about her. We want to talk to the patient first, treat them like a real human being, and then if we can't get anything from them, we can talk to caregivers. Or your partner can peel away and talk to caregivers. Then you guys can meet up and go over what you found. Scene size up and safety. Look inside and outside residence for clues to physical and mental abilities. Now, what's the condition of the residence? Is there half-eaten food laid out? Is the house dirty or clean? Is there a wheelchair ramp as you pull up? Are items left out that the patient can trip on? Do they have little rugs everywhere? Rugs are trip hazards for old people. Not good. We should take them all away. So our primary assessment, we're going to form a general impression. We're going to assess their mental status. We're going to assess the airway, breathing, circulation, and identify patient priorities. Priority patients. Older people are twice as likely to use us, so guess what? We run a lot of geriatric patients. Finding your pulse, radial pulse in an older patient is usually no different from finding a pulse in anybody else, okay? We can normally find these pretty simply. We're going to do a secondary assessment. We're going to get a good history. Take time needed to get the full information. These people answer slowly, so it's hard. If you're trying to rattle off questions, it frustrates them and makes it difficult to have success. So don't do that. Be patient. Give them time. When was the last time you had something to eat? And yeah, you have to wait a while. And then you can go to your next question. What kind of medical problems do you have? And then you have to wait a while. It can be frustrating for us, EMS caregivers, because we try to move quickly. We can also ask family members, others familiar with the patient condition. If my partner's talking to the patient, I'm going to try to get that information on the back end. We're going to go do a good physical exam and get those baseline vital signs. Okay, we're going to start with the head and neck, chest and abdomen, pelvis and extremities. Remember that hip and proximal femur fractures are common because the elderly are kind of frail and they fall a lot. Okay? They have weakening of bones, results in injuries to wrist and proximal humerus. Extrication of an elderly patient from a motor vehicle can be difficult. They have a curvature of the spine that can cause some problems. We can't land flat on backboards most of the time. We do need to seek all these people, and sometimes they have like no neck, so it's very difficult. Okay? This is a shingles rash. Picture of that. Often appears as like a belt-like a band across the torso. It's very, very painful. So that's something you might find on a secondary assessment, right? Steps of that physical exam, the pelvis and extremities. We're going to check extremities for edema and swelling. When significant, these can be signs of underlying heart, vascular, or liver diseases. Okay? We're going to look at the spine. Very commonly injured in motor vehicle collisions. They have abnormal curvature. May make immobilization difficult. That's what I was just talking about. Do your best to keep vertebrae in alignment and reduce patient's discomfort. Okay? We can't make somebody lay flat if they aren't physically able to. That's not going to help the patient. Reassessment's more common for older adults to show a slow, steady decline in condition. You can be lulled into a false sense of security. Everything appears fine, everything appears fine. Remember that heart rate's a little slower than you would expect in a trauma patient. All of a sudden it slows down some more, you're not paying attention, and the patient goes into cardiac arrest because you're not paying attention. It's a bad day. So be alert. Watch your patients carefully. Reassess at regular intervals and compare with previous findings. Remember, check the pupils. Pupils are huge in telling what's going on with these patients, okay? They may have a head injury that you don't know about. Check those pupils. Reassess mental status and maintain an open airway. We're going to monitor breathing, pulse, skin color, temperature, and moisture. Reassess vital signs every 5 minutes if they're unstable, or 15 minutes if they're stable. And if you're not sure, go with 10. Ensure that all appropriate care and treatments are being given. Remember that we got to calm these patients down. This may be the worst day of their life. They may be worried about if their driver's license is going to get taken away, if their family's going to pull their car from them. Who knows what's going on? So you got to calm them. You got to talk to them like they're a patient. Remember? What is commonly seen when assessing elderly patients' blood pressure? It's probably going to be lower than we're expecting, right? Not going to be as high. Commonly fractured, we're going to see a lot of femur and pelvic fractures. And then challenges, they've got that curvature of the spine going on. It's going to be difficult to backboard these patients. So some illness and injury in older patients, elderly patients prone to some problems because of their age-related issues. They typically present a little differently than in younger patients and may present with vague signs or symptoms, or they may not be able to communicate those to you. A lot of times these patients are not compliant with their medications. Sometimes they don't have the money to buy their medications, and so they're buying food instead. They can't afford their medications. And then a lot of times these guys have like pharmacosis, where they're getting multiple medications from multiple providers, and they're really having problems with interactions between the drugs. So, and these patients have a hard time clearing those medications from their system, so they get a lot of buildup of different drugs. We get drug-to-drug interactions and cause a lot of problems. This is a very normal scene at most patients' houses. They have been prescribed 52 different medications by 47 different doctors, and they don't all know what the other ones have prescribed. It makes for a very challenging situation for us to figure out what's going on. It's best to take all those medications with us to the hospital, give them to the ER doctor, let them make a decision on what to do from there on that side. Shortness of breath can result from diseases that cause such symptoms in younger patients such as asthma or pulmonary embolism. Elderly patients are more likely to have emphysema or a combination of these diseases. Chief complaint of patient experiencing a cardiac problem is normally shortness of breath, so we got to be aware that it could be cardiac in nature. Complaint of chest pain may indicate many conditions. Could be angina, myocardial infarction, which is a heart attack, pneumonia, or an aortic aneurysm. Altered mental status can be due to adverse effects from medications. Could be hypoglycemia, so we need to make sure we check the blood sugar on every altered mental status patient. Every possible strokes patient, every possible sepsis patient, you should check a blood glucose on to make sure we're ruling that out. Nothing worse than calling a helicopter for a stroke turns out to be a blood sugar. That's really, really, really embarrassing. And we wasted somebody's lot of money to fly a helicopter there. Could be a generalized infection in the bloodstream, hypothermia, pneumonia, a lot of things. Abdominal pain and GI bleeding. Could be a abdominal aortic aneurysm, a bowel obstruction, diverticulosis, internal bleeding, cancers of the GI tract, ulcers, or adverse effects of medications. Okay? Dizziness, weakness, and general malaise. Don't take these complaints lightly. These patients still have a severe problem most of the time, especially if caregivers or family members say, this is not like my family member. This is not like my grandma. She's so much worse today. You need to take any time a caregiver tells you something, you need to take that very seriously. If they say, this is not my grandma. This is not my mom. Please, please, that is a good indicator that something different is going on today. This patient had a serious change. Maybe they are having a stroke. Maybe they did have some sort of head trauma. We need to take that very seriously and make sure they get checked out. Okay? So make sure you're taking those complaints seriously and you're watching for them. You're doing a good assessment, making sure you're checking sugars and all that good stuff. Okay? Got to be diligent. Got to be diligent. Even when we run these calls every day, we've got to be diligent to make sure we don't be complacent. Depression and suicide, also a concern. A lot of times we get complacent on this one as well. See a lot of elderly people that have depression listed. so we start to think it's not a big deal. But it can be deadly. Even if they don't kill themselves, it can be deadly because it limits their activity. They are on medications that may sap their energy. They have loss of friends or a spouse. Think about it. As you get older, what happens to your friends? Yeah, they die. It's really sad that they die, okay? So grandparents, their friends are constantly dying. That's all they see. It's going to make them sad. Rash, pain, and flu-like symptoms could be shingles, herpes. The virus reawakens after years, appears as belt-like band around the torso, scabs over after a few days. It's very painful on the side of the torso. And the EMT can contract it from fluid. So we've got to have our gloves on, got to have our appropriate PPE. Falls. Death may result from complications of falls. Bruised ribs, cannot cough because of pain. May indicate more serious problem, abnormal heart rhythm, stroke, internal bleeding. Assess for cause of fall as well as injuries from the fall. Falls are a big time problem in the elderly. We also have to watch for elder abuse and neglect. This can happen at homes, at nursing homes, pretty much anywhere, okay? They can be physically, psychologically, or financially abused, and it can be difficult to detect. Many states have laws that require reporting. We do have mandatory reporting of elderly abuse. So make sure if you see something suspicious, you report it. Sometimes you get in that situation where you're not sure. When in doubt, report and let them come in and decide, okay? Over time, one member of a couple often becomes a caregiver for a sick partner. If the caregiver becomes sick or injured, their situation may become difficult or impossible. Caregiver also has a lot of guilt, and it can turn into burnout. You may need to make short-term arrangements for the partner. So if the caregiver's sick and has to go to the hospital, and the partner's chronically ill or chronically needs assistance, you may have to transport both of them to the ER for them to have a resolution, so that that person's not left there alone in a dangerous situation. Shingles rash can appear anywhere on the body, including the face. Here's a good picture of one starting to work there on the face. Probably hard to see in this, but you pull up the PowerPoint at home. Loss of independence. Help the patient who's losing independence, help them adjust. If you're at their house for a fall, help them set things up so that they can work together. Maybe get them resources. Contact a nursing home to see if they have any room. I've done that before. Sometimes these turn into more community paramedicine, community EMT stuff, but it's good and helpful for the patient. Got to continue to treat that patient with dignity. Do not minimize their fears and concerns. They're real. Help them lock up if they're leaving. Maybe call family members to help take care of their pets. Be reassuring, be empathetic. Remember, this is a bad day for them. They don't want to be leaving their house of 90 some odd years to go live somewhere else, so you got to help them, okay? Remember, some of these patients are going to have Alzheimer's or memory loss diseases. We're going to have to work with them, be empathetic, make sure that we're not treating them like they aren't human beings, even though they may not know what's going on at all. All right, that is geriatric emergencies. We deal with a lot of geriatric patients, so make sure that you pay special attention to how to treat these patients.